from New York Beth Israel, and we'll go through our articles. I guess in previous weeks we're working on the audio. We'll see how the audio is doing this week, and we'll have Journal Club next week. Next week we're in Neptune at Monarch Education. No, actually next week is the fifth Wednesday of the month, right? So next week we are off. Is that right? Yeah. So next week we're actually off from Journal Club. Remember, the first and third are always at New York Beth Israel. The second and fourth are at Monarch. And whenever there's a fifth Wednesday, we just do operations, don't do Journal Club. So we're just doing operations next week. The fellows and faculty have to come, and we'll get started. So thanks for tuning in. We'll just start with interesting cases like usual. Anybody have an interesting case? Either pre-hospital or the emergency department? Who's on primary?
I was on primary, but it was kind of a short week just because of our board exams and the way shifts worked out. Primary calls, there's a lot of calls, but none that were kind of standoutish. The only interesting one was a motor vehicle wreck, pretty significant mechanism, car versus pole off the main highway, both airbags deployed, pretty significant front end intrusion. But we had a lot of difficulty finding the patients. For some reason, they ended up, I guess BLS picked them up and then was going to do line of sight, but kind of went off the highway and was under a bridge, and it was just really kind of a long delay in both ALS getting there and me getting there, even though we clearly saw the accident site. And I had driven by and I was like, that seems weird that a BLS truck is like close, but clearly on another road. And they had ended up taking both patients. They both had kind of abdominal complaints. But normal vital signs, it seemed like kind of at the end of the day, it was mostly drug intoxication. That was really what got them so concerned, because they thought they were altered, but really they were just sleepy and pinpoint pupils, and presumably had OD. Got some Narcan, woke back up, and then were fine and transported to the hospital without much incident. But I think the most interesting case I had was in the ER at one of our core sites. I had a patient who came in complaining of coughing. Had about a week or so of upper respiratory like symptoms, but came in today because he had severe right-sided pain, right-sided chest pain. So the resident went to go see them, and a couple minutes after she went to go see them, she's like, "You should come here and see this." So I was like, "Okay, maybe this is PE or something else." I'd already read the triage, kind of seen them come by. Went in there, and basically she said, so he was coughing for a couple of days, and this morning all of a sudden he had a bad coughing episode, and now has severe right-sided pain. And on exam, he had a little area of swelling. So we got the ultrasound. We looked at the ultrasound. There was a pretty big, maybe 5 or 10 centimeter area of echogenic material that kind of suspicious for maybe clot and bleeding. He was on aspirin and Plavix for a recent stint about 6 months ago. But there was also a small area of this echolucid area within this hematoma, what we were presuming, that kind of concerned us for active bleeding. So we ended up deciding to CT him, got a CT angio actually after talking with radiology and kind of deciding what the best test was. Turned out there was active bleeding from a small thoracic artery, which apparently was just a random thoracic artery rupture during a coughing episode. And then the complication became, well, now he's on aspirin and Plavix. Do we need to reverse this? By the time we gotten back from CT, it went from 5 or 10 centimeters to 20 or 25 centimeters, almost down all the way to the iliac crest of pelvis.
What blood thinner was he on?
Aspirin and Plavix for his recent stints. He's had 5 stints in the past. Most recently, I think it's
so
5 months ago.
Spontaneous rupture of a superficial vessel.
A thoracic artery.
Thoracic artery.
Yep. And then it kind of got worse and worse.
Can that be embolized?
So that was our plan. So we said, let's hold off on aspirin or trying to do anything with his blood reversal. His blood pressure was good. He wasn't tachycardic. We had good IV access. So basically, we reached out to IR. IR looked at the films in the case and said, I don't think this is somewhere I can get to. This doesn't look like something I can embolize. By this time, it's now 30, 35 centimeters. It's a rapidly expanding hematoma. So we also call vascular surgery down. Vascular surgery is
no trauma.
There's no trauma. It was just a coughing episode.
Yeah.
Just a coughing episode. Vascular surgery gets down there. By the time vascular surgery gets down there, they walk in the room, and his blood pressure is 70 over something. And the vascular surgery is very concerned. Of course, it was a little odd that he'd been good this whole time, and it was rapidly expanding. We were concerned for active bleeding. He hadn't really had a drop in blood pressure. So we were still waiting on his cardiologist to get back to us after a third or fourth call. But at this point, we're like, he has low blood pressure. We gotta intervene. And actually, this gentleman's specialty happened to be in blood bank, so he was very well versed in blood products and other things. So he had a lot of opinion. But at the end of the day, we just kind of all came to the conclusion that we should give you platelets. Although aspirin, it's kind of a Hail Mary because it probably won't make a big difference, especially the platelets.
Well, right.
But then also we ended up giving him TXA because
Great.
we were very concerned that this was still an active bleed despite some compression.
So you give him a gram of TXA. That's great.
Gram of TXA. And then at the end of the day, vascular surgery called around and called friends in and got a different IR person who's like, listen, we've got to do something. And openly exploring it is unlikely to get to the root of the cause. So they ended up taking him to IR and were able to embolize it.
So he did embolization.
Stop his bleeding. But by the time he left, he had a very, very, very large, actively expanded hematoma.
Really?
Very large, which is very surprising. You kind of would have thought it eventually would have tamponaded off. There's just only so much space there, and it presumably was a smaller artery. It wasn't super hypertensive. But
so, we reviewed reversal of 10A inhibitors and direct thrombin inhibitors last week by that article from our friends in Chicago about how to reverse it and giving Praxbind, giving TXA, giving Kcentra, giving customized platelets, and it was a nice article. A few of you sent me the article from Annals of Emergency Medicine. That was a bigger paper, which we'll review actually next week. I'll throw into the Journal Club next week. But I guess no thought of giving Kcentra. I know he's not on warfarin.
Right. We actually did think about that. He wasn't on warfarin. It was just aspirin Plavix, but we were kind of like really reaching there because he was still actively bleeding and to the point where we were concerned that he was becoming hemodynamically unstable. Turns out once we calmed everything down and I repositioned the cuff and took a blood pressure, it was normal again. So it probably was just an error in the reading, but it did get everyone excited for a little bit.
Right. Interesting. And then IR finally took him.
And IR took him, and then they were able to make it there.
We used to take everybody to the OR for everything, and now we don't in trauma or even these things. Even my rectus sheath hematoma that we talked about a few weeks ago, I gave TXA to. Did the TXA help, do you think? I know it's just subjective. TXA helps for everything.
Right.
Everything.
Right. There was no downside, and this was clear. I really should have given it early. That was my only retrospective review. Early on, we should have just given it because even right after CT, it was clearly expanding.
Right.
And that's the point.
And how much FFP did you do? Or did you get?
We didn't. I didn't give FFP.
No FFP.
Yeah,
obviously that's reversal for warfarin classically. However, if you were going to give FFP for warfarin, how much would you give?
I would give 2 units of FFP.
Right. So it's 15 per kilo, 15 mLs per kilo. It's the mistake we make is most people need at least 4, especially if they're having intracranial bleeding and they're on Coumadin.
That was an interesting
case.
And interestingly, we were really pushing vascular surgery. In fact, I called the attending and said, I want you to come in and really look at this person. And they did, to their credit. They were there very quickly. But even there, they're like, no, this is now transitioned from, this is not an intraoperative management anymore. This is IR management. Right. So, which was interesting.
Yeah.
Were you able to see where, with the angio, where there was extravasation or the actual vessel?
So I think you saw blush on the CT angio.
They saw blush on CT.
Because that's a classic finding. You see blush on CT angio. They saw blush.
Right. But the first IR interventionalist thought that they just weren't going to be able to get there effectively to embolize.
And there was absolutely no trauma.
No trauma. He was like, I was coughing. As soon as I coughed, it hurt right here.
Right. This is what we had. We heard a couple of splenic artery aneurysms where people pre-hospital, where young people just get really, really sick, and then on CTA they have a splenic artery aneurysm rupture, and very challenging to figure out before you image why.
I was telling Alex, our other incoming fellow, this is the same story. He's like, actually, I had a very similar case in the ER where he works. Another young, healthy person had a coughing episode. After that, she's told her mom, I feel really sick, lightheaded. She syncopized. She went into cardiac arrest. They were able to kind of intermittently get her back, ROSC, arrest. In the ER, they were able to get her stabilized enough to try to get her to surgery. And then they ended up thinking that this was some kind of bleeding because they saw blood in the belly on the fast. They didn't know where it was from. And at the end of the day, it ended up being a spontaneous liver laceration. It was just massive bleeding into the abdomen. causing her to go into
So we
arrest.
keep seeing these cases, these spontaneous ruptures, or spontaneous aneurysms of bleeding. And it's interesting, you always have to think about it.
Right. It's something you would not kind of pop to your top.
I mean, you have celiac artery
arrest.
aneurysms. In fact, there were studies to say that when you actually palpate the abdomen, it's usually not your aorta that's pulsating, it's usually your celiac artery that's pulsating. In most of the cases, your celiac artery can rupture spontaneously, but splenic arteries are known to have aneurysms and rupturing spontaneously. I keep seeing this more and more. I'm not sure why. I don't know if it's uncontrolled hypertension, but we had like two 30-year-olds and one 20-year-old with a spontaneous splenic artery rupture, too. Yeah. All right, that's good. Anything else in the ER pre-hospital?
I had an interesting case yesterday. They called me over for a seizure on the Garden State Parkway. And then I got there. I was already in the back of the BLS ambulance. There's obviously a lot of apparatuses on the highway blocking off right after the toll booth. The medics in the back said the guy was like very combative. He was diaphoretic, and they thought maybe his blood sugar was low, so they gave him some dextrose. I guess they had checked the finger stick at around the same time. I guess around the same time they were giving the dextrose, and it was 71. But the guy just looked really bad, very diaphoretic, out of it, and wasn't really making sense or kind of answering any questions. And the call came over for a seizure, but I don't know how anyone knew that this guy had a seizure. And I guess the guy had a CDL license, so someone mentioned, well, if he has a CDL license, you can't get a CDL license if you have seizures. So we weren't really quite sure what was going on. The IV that was put in by the medics at first was ripped out, I guess. The guy was flailing all over the place. We were on scene for a little bit. After about me being there for 5 or 6 minutes, I'm like, we just got to get out of here. The guy just really did not look good, and he started vomiting. And at that point, I'm like, I don't know what is going on with him, but I don't want to be on the highway in the back of the ambulance because this guy needs to be in the hospital. And
How old was he?
He was 60. And slowly he's started getting better, but had persistent vomiting and was diaphoretic. And then the discussion kind of came, which hospital should we go to? Should we go to the closest one, or should we go to a trauma center at this point? And
to me, persistent vomiting in non-traumatic setting, I think of the worst stuff. So, I think of brain or belly, right?
Yeah.
So 2 Bs for persistent vomiting, for the bad stuff, and certainly for the brain, I would think of intracranial bleeding or something making your ICP go up, a mass or something, or just bleeding. And belly, I would think of almost anything from pancreatitis to, simple gastritis. Cyclic vomiting. What else could vomiting? Cholecystitis, gallbladder disease, APIs, any intra-abdominal process, gastroenteritis. What else? Obstruction, right? Obstruction, anything in the bowel.
Would it cause him to be unresponsive?
Well, he was unresponsive.
Right, so at first he was very confused and kind of not really responding and combative and not making sense. So at this point I wasn't sure if I don't know, the call came over for a seizure, so I don't know if he was maybe post-ictal. The medic said that his sugar was 71, but then they gave him sugar and he started to get better, so I don't know if. So at that point, I'm like, all right, maybe this guy's normally 300s or 400s, and it's a relative hypoglycemia for him, and maybe he was hypoglycemic, or maybe he had a seizure and then was post-ictal and now is getting better and had nothing to do with the sugar at all. Or he had a seizure, then was in a car accident, and then something bad happened to him in a car accident. Although it was right after the toll booth, so presumably he shouldn't be going too fast at that point. And the car, from the report that I got, was not severely damaged. I decided to go to, at first we were going to go to, they wanted to go to a closer hospital. I said, I think we should just go to a trauma center because, I don't know, I can't differentiate at this point kind of what's going on with him. So we decided to go to the trauma center, and as en route, he started waking up and making a lot more sense. Then eventually told us that he does have a seizure history.
Do you think he was altered because he was post-ictal?
So I think he was altered because he was post-ictal. And then at that point, I'm assessing him, and it really doesn't look anything wrong. And I'm thinking, should I cancel the trauma activation? Because I know that if I bring this guy into the trauma center, he's going to get, at this point, an unnecessary pan scan.
Well, don't say that. We don't know that.
Well, right, but I think there's a much higher likelihood of him getting additional imaging and other tests that maybe he needs or doesn't need. Because now at this point, he was really making sense, and so he still was vomiting. So I said, I'm not going to cancel it. He's still vomiting. I don't know if there's something wrong with his head. We get to the hospital, and the whole team comes down and assesses him. And immediately the first thing they do is put a collar on this guy who's actively vomiting, and even though he's got no neck pain, so now he's got the collar up to his eyes as he's throwing up into the collar, and I just can't help but think, what's the utility of doing this? We do this to check off a box. Is it helping?
Well, we know around the world people are not using servo collars
Right.
anymore. Like in Fresno, California, they haven't used it in decades. So around the world, people have gotten rid of cervical collars. It's certainly not universal. It's certainly not the majority of people. But there's certainly some evidence that you displace type 2 odontoid fractures. You put on perfectly placed seat collars. We don't put on correctly a lot of the time. And you auto splint your SCM and traps. So that's probably a better splint than the collar. But the majority of the world still hasn't bought into that.
Yeah. So he ended up getting a pan scan.
Anything
And
positive?
no, it was all negative. So it was just an interesting case. I think just a couple, points that are brought up are, deciding which hospital to go to when you have a mixed picture. I think in these cases, I think it's important to have an emergency physician that is taking care of the patient when they come in with the trauma, because trauma doctors are not as well versed in the medical aspects of care. When you have these mixed pictures, I think the ER physicians have a more global picture kind of everything they're focusing on. Because the ER team seems to have been working on their own for the medical stuff, and the trauma team is working on their own for the trauma stuff. And then
Sure, and in many
coordination
places the ER does all the primary assessments for trauma anyway,
Yeah.
depending on what hospital you go
Right,
to.
so it depends on what kind of hospital. But to me, I think it's these cases where I think it makes the biggest difference as to who's taking care of the patient. If it's pure trauma, then trauma's fine, taking care of the person, or ER is probably fine. When it's the mixed pictures, I think there needs to be a good dialogue between the two services, and if they're both there, but when they're working independently of each other, I think it's a disservice to the patient.
I do believe the longer period that you're seizing for, the longer period your post-ictal time is, right? I mean, if the guy was agitated and you need to control him and he was seizing, or he had just seized, ketamine would be a great drug, right?
Yeah.
Because ketamine certainly we use all the time now for benzo-refractory seizures. So when benzos don't work, there's literature, right, in both adults and kids. You have about 10 papers out there. Although some are review articles, some are original research that for benzo-refractory seizures, in both adults and kids, ketamine seems to be a great choice, and ketamine works by multiple mechanisms as opposed to benzo just working by one. So we like it, and we send papers to people all the time who've never heard of this, but it's not new in literature. What's it called when you're paralyzed after a seizure?
Thoughts paralysis.
Right. How long does so you can't move your arm after a seizure? It's called TOTS paralysis. How long can TOTS paralysis last for before it's no longer TOTS paralysis and you think there's something else going on?
It's 24 hours.
Yeah. So some very old neurologist who was like 110 asked me this when I was in neuro many years ago, and he said, Dr. Merlin, the answer is 6 days. TOTS paralysis can last 6 days. I said, I'm just curious. Is that, I was a little tough. I said, is that based upon paper? And he goes, nope. He goes, I've been a neurologist for 40 years, and I have seen TOTS paralysis up to 6 days. That's why I tell people 6 days. And I said, all right, that's interesting to me. So the point here is TOTS paralysis can last several days, and you can still get better. Right? So I take that at face value and do it a long time. So that kind of makes sense to me. All right, other interesting things?
I think the real learning point from that, though, and the thing that I remember being like a real light bulb moment for me when I was in residency and on the trauma service, is like a lot of these traumas are something else. So like it's probably lost, especially to new EMS providers. You're on the scene, it's a bad car wreck, you're thinking all of the things that's going on with the patient must be trauma related, when really it might be a stroke, an MI that caused the wreck.
Is that the person grabs their head and collapses?
Right.
Did they hit their head on the way down,
Right.
or did they
Right.
have
Which
a ruptured
first?
aneurysm, or did they hit their head and have a traumatic subarachnoid? And the truth is, we don't know, and we'll scan your head, and we'll probably, we'll scan your stomach probably. And, if the ERC probably really doesn't even matter. But there are certainly people in trauma service who have ruptured aneurysms, which we don't know till we get CT angios. Now, we'll talk about CT angios in a second. Maybe we do know quicker now that certainly we've known for years, if you were subarachnoid, you should stay on the table and get a CT angio before you leave the table. Now we can say, in terms of adults, probably should always get a CT angio before you leave the table, always. Right? And we're doing pre-hospital. Anything else interesting in the ER or pre-hospital? Anybody have any questions at home?
Nothing so far.
Nothing so far. All right, who's in the first article?
I can do the first article. And what has to be just the sexiest thing ever, a pre-hospital CTA. Doing not only pre-hospital CTs, so I've seen these trucks. I think I first saw it at ACEP on one of my conventions that we went to. And it's basically an ambulance, and at the front where the kind of the bench of the captain's seat would be for the airway is a CT machine, big CT machine. With the idea being we can dispatch this unit to calls that the dispatcher, through their standard questioning, identifies as a likely stroke. And then they can get a CT head right there on the scene. Of course, you can't be transporting while this happens, so you kind of have to do it right before you leave. And then you can see, is this a ischemic cause of stroke or a hemorrhagic cause of stroke? And that might differentiate where you go, especially because the hemorrhagic cause would often need neurosurgical intervention, or at least need to be in a place that can do that. So this study was over 2 years. Primarily, I believe it was out of Germany, although the UK kind of was also involved. And they looked at 51 patients where they did exactly that. This mobile stroke unit was dispatched in conjunction with an ALS unit to calls the dispatcher deemed as being a likely stroke. And then on the scene, the 51 patients, 22 men, 29 women, that had a median age of 73, that had symptoms of an acute stroke, but got both a regular CT head, so CT without contrast, and then also a CT angiogram with contrast to basically look at the vessels to primarily identify large vessel occlusion. And then through the paper, they talk about several different patients that this technology specifically helped in and specifically differentiated management. I think the details of which cases, basically a person who was bleeding and then another person who had a very large vessel occlusion that was found on CT angio that would not have been seen on CT. And then they directed the patient from a standard stroke center to a comprehensive stroke center. The difference being the comprehensive stroke center presumably had neurosurgical intervention where they can do an endovascular retrieval. So in standard stroke, we are kind of limited to the 3.5 hour to maybe 4 hour mark of when we can give thrombolytics if we determine it's a non-hemorrhagic stroke. But when you have an endovascular intervention through neurosurgery or sometimes IR, you can actually go and extend that window to the 6 and maybe even longer mark to go get that large vessel occlusion. And I actually have had many of these patients myself working at a prior center that had this. They were outside the window. They had a large major deficit, like total aphasia and large hemiparesis, really life-altering. They were outside the window of TPA. Maybe they had a risk factor or a relative contraindication to TPA. Usually it was just because they were past that time mark. But then they were taken by neurosurgery, were able to get out a big honking clot, and then they had great neurologic outcome. The patients that they talk about in this specific paper, not all of them had dramatic outcomes. A couple had good outcomes. One or two had poor outcomes just because of the nature of their disease. But the really point of the study was, is this a viable option to do a CT angio? And I think it's a really interesting concept, especially as CTs get faster and they can be more high resolution. And especially if it was a rural service that maybe your closest hospital is 30 minutes away, but your comprehensive trauma or stroke center might be 3 hours away, that could make a difference in where you transport. But in the study that they were in the place they were at, really their hospital times were a place that was 11 miles versus a place that was 7 miles. So it really wasn't that big of a difference. And I wonder how much time you would spend on seeing. They said that the CT head took about 4 minutes and the CT angio less than 5 minutes. So it's really not that significant amount of time. But I just wonder how much utility there is in a system, because these trucks are extremely expensive. They had to have telehealth to basically talk to the neurologist to decide when to do the scans. They also had to have telehealth to the radiologist in case they needed more specifics about how to adjust the scan, and then they needed the CT tech to run the CT scanner because you have to put in certain parameters and you have to adjust doses. It's kind of a complex process. It's not as simple as pushing a button. I just wonder, like, the amount of money you spend on this, is it really effective?
It's a good question, and it's tough to honestly answer this in the literature.
Yeah.
And we've reviewed a couple of studies now which question the utility of these, because you have to do a lot of imaging for a very small population to benefit from TPA. For someone that's extremely expensive, and it's difficult to have show outcomes differences of people who get this versus get in the hospital. But that's not a very popular point for people who are spending millions of dollars to start these services. And we know that we're still not doing a great job in the emergency department because, at the NEC conference, Northeast River Respiratory Conference, for the last 3 years, people have been saying, leaders from around the world have been saying that everybody who goes to CAT scan for imaging of their head should get a CT angio at the same time before they leave the table. And I just was at the New Jersey Stroke Coordinator meeting giving a lecture, and most people in New Jersey in our state are doing this, and most people in major centers are doing this. But NEC has said it the last 3 years. You go to CAT scan for anything neurologic, right? You should get a CTA before you leave the table, period. We used to just say this for subarachnoids, where you receive look for ruptured aneurysms, but now we're seeing for intracranial bleeds, for strokes, period. And so we're not doing it very well in the hospital. It's funny how we might be doing it better in the pre-hospital setting, once again, in the hospital. But, and certainly we could think something we could pick up are dissections, right? That we'll miss on a regular CT head. And we'll see the clot and see lesions, see other stuff that we may miss in a plain CT head. And it takes, an average of 3 minutes more. That's it, 3 minutes more for the injection. You don't need renal function, right? Because it's an emergency task. And for 3 more minutes to stay on the table, when if they go back to the emergency department, then they go back, nursing has to call transport again, they have to get another order put in. It really doesn't make any sense to have them go back a second time. I guess you can make an argument that if you're going to go to MR really quickly, like a very, very small amount of hospitals do, if some do this, then sure, you can come back and go right to MR, if that's realistic. But even MR is not quick, because you need MR checklists, and most of those are not evidence-based anyway. So what do you think?
So to answer the question of the article, if we have a truck that goes out there and gets a CT, absolutely they should be getting a CTA. That makes total sense.
Yeah.
Another limiting factor is once they got the CT, then they had to bring the patient and then the produced DVD to the ER, and you have to have not only a systems set up, because half the discs that are brought in, they're not compatible or they can't be read. You have to set up a whole bunch of things. And I just think that maybe the better way from a systems perspective for this is anyone with major deficits in the high NIH stroke scale, they probably all should be going to these comprehensive stroke centers, whatever their time mark, because a lot of these patients will be able to get this embolectomy and they might have a good outcome. Whereas if they went to a small stroke center, they don't have the availability of those resources, and by the time you can set up transport and everything, it's now too big. So that may be a better focus and a better pooling of resources.
That's Dr. Parrish's opinion.
That's
no reflection
mine.
of
Absolutely.
journal stuff.
I think
it's a valid opinion.
But if we're able to get these strokes, especially looking down the road, when we can have, these, just like we have bariatric trucks, we have specialized trucks, and we can send them out and the costs come down. I think that this is going to be a real thing. This is exactly what we're trying to do through this fellowship, is expand the realm of taking ER to the patient, and that's what this can do. Right. It's just, I think we're at the early stages.
If you're going to do the CT on scene,
absolutely,
do the CTA on scene.
Absolutely. And I think that was the question of the study, and that.
And you agree that if you're saying somebody for CT of their head, you might as well do CT angio.
If they have neurologic symptoms, they should be getting CT.
Yeah, and if it's a bleed, saying keep going. If it's a non-bleed, keep going. It doesn't matter. It's sort of like figuring out what the problem is without defining anatomy and what caused it in the first place. Right. It's silliness. It's like when before we used to do, IR on belly issues. And image everybody. We would just say, you have blood in your belly. Let's go to the operating room. When it's stable, we'll see through them and see exactly what's bleeding, and maybe there's blood, maybe they're appropriate for IR. We define anatomy. That's what we're doing more and more. Same thing out of a CT of your coronary arteries. In some patients, is replacing getting stress tests. Right? We're defining anatomy. We're seeing what the anatomy is. It makes sense.
What do you think about perfusion studies?
Yeah, I think a perfusion study for me is if you're outside the window of the, for me personally, by the literature, it's 4.5 hours. If you're outside the 4.5 hour window mark, then the CT perfusion is the right thing to do. So I think you hit the door and you get a CT head, CT angio head, and CT perfusion if you're outside the 4.5-hour window.
Okay.
If you're within it, then, in my experience, a CT perfusion in most centers is a really, really quick test because we're still at the learning stages. And to me, if you're going to get TPA'd, and I'll be supportive of that if there's a clot by CT angio, usually, in the MCA or large vessel occlusion, really, then that it makes sense just to go ahead and give the TPA before you get a perfusion study. And, when you get a perfusion study at that point, because you can take them to MR at some point.
Right.
Well, what do you think?
Yeah, I agree. I mean, I think a perfusion study is only kind of really it's looking for that penumbra at the end of the day.
Yeah.
And I mean, what's the utility of that? It's really when you're outside the window. And I think that's reasonable. To your comment, I mean, the other studies out in Germany, as of, I think, 2 years ago, the Houston Fire Department started having a mobile stroke unit.
Yeah.
They
I
had
met the guy who ran it, the stroke neurologist at NAC, I think, 2 years
right.
ago.
And I mean, they just started it, so I'm hoping they'll push some data out. But basically, one of the things that we always talk about is the utility of TPA and whether or not, its effectiveness is really there and the risk versus benefit of bleed. That being said, I think that, attacking these patients in the pre-hospital setting, getting a CT done prior to even arrival, and then even being able to give TPA pre-hospitally is actually pretty good because you're now getting it within 1 hour. I mean, within 1 hour of onset of symptom may actually increase outcome. The problem that we're having is patients present to the ED, they're usually maybe 30 minutes, at least 40 minutes into their symptoms.
Or
And
their
now-
wake-up stroke.
Right, so they're a wake-up stroke. And now they're going to basically have to get CT imaging, and then they have to wait for labs to come back, and then essentially you've got this lag. And so you're usually into your second hour by the time there's a decision to give TPA. What the Houston Fire Department has done is basically they're doing the CT en route, and there's actually a neurologist actually in the actual vehicle with you. So the neurologist is actually in the stroke vehicle. He's actually doing the
They got a
assessment.
grant for it.
Right.
There may not be a neurologist in the future.
I doubt it's going to be sustainable. The issue is that you have to have like a CT tech really there. You're going to have somebody able to send the images portably to a radiologist who's going to be there. Now the neurologist has to be able to interpret this and then mix the TPA and give it. And this can be given, they have iStats basically that will allow them to basically look for coags and coagulopathy and whatnot. So it's an interesting concept. The question is, what's the viability of it? And really the true, kind of in an urban setting, and this study that was done really was in a hospital that was outside their main medical campus, which is, they had about a 3-mile radius. So it really wasn't that far away. The question is the utility really there for, the rural setting, where you've got a very lengthy transport time, and now you have somebody with a stroke. Well, the question is, how many of these vehicles can you get? What's the cost of these vehicles? And what's the cost versus benefit,
Right.
And
TPA is certainly not without risk. I mean, the NINDS
Sure.
trial quoted 6.1% rate of intracranial bleed. You have much higher chance for bad outcome if you have intracranial bleed from TPA. The Cleveland area experience had about 15% rate of intracranial bleeding, and those were community hospitals. So the rate that we quote sometimes to patients of 6% intracranial bleed is based upon an NINDS trial of multiple academic centers where people had all these stroke protocol people there, and if you were going for a TPA inappropriately or had a contraindication, they recognized it really quickly. So it's probably closer to 15%. And the true antidote to hemorrhagic stroke or hemorrhagic conversion from TPA is TXA, which most people don't give because it's not in the neurology literature, even though I think we've recognized that it really is a true antidote for it.
right. And Joe Matthews says that they're the first MSU in the state of New Jersey that has this kind of in the pre-hospital setting.
Yeah,
I don't know,
I mean, we're supportive of it. I mean, anytime you can get somebody into CAT scan imaging quicker, I think, I think that's a good thing.
Yep.
Will the utility of them pan out in the literature? I don't know that it has so far. I guess it's possible. It is an expensive thing. But, if you can show me that you can get imaging on people with CT hen and CT angio and get it read quicker, to me that makes sense, especially because some of these people won't have strokes. They'll have intracranial bleeding.
Right.
We have a clinical pearl about this. How do you tell the difference between a stroke and intracranial bleed by clinical exam? And the answer for the 100th time is you cannot.
Okay.
There was one study which showed a high diastolic blood pressure is more associated with intracranial bleeding. And if you're really altered, you're much more likely to have intracranial bleeding than a stroke. But besides those two factors, if you look at our clinical pearl, there's really nothing that can tell the difference clinically.
Sure.
If somebody comes in hypertensive, hemiplegic, it could be a stroke or a bleed. I just don't know. And that's the bottom line. So everybody needs imaging. That's what makes me nervous about people doing too many stroke scales in pre-hospital setting. Even if your stroke scale doesn't dictate large vessel occlusion, you still need an imaging test, right? So
Right.
whether your blood pressure, and no stroke scale is 100% sensitive, 100% specific, because we don't want it to be. We want to have, we have to build in some error into it, although we'll be, anytime you're too good at something, you need to be picking up people who you have misses for, or you're going to under triage people, right? And that's a statistical fact. So, if a stroke scale is totally fine in the back of a moving ambulance, that's my philosophy. A stroke scale while sitting on scene is the wrong place to do it.
Right.
Okay, who's doing the next part?
Talk about the effect of successful intubation on patient outcomes in out-of-hospital cardiac arrest and type A. This I thought was actually a pretty interesting article.
Yeah, this is an interesting article. I sent this to a bunch of people too who were interested in TPR.
Yes, I thought this was an interesting article. I mean, it basically looked at intubation in patients in out-of-hospital cardiac arrest, and what they were looking at was the primary outcome was survival to discharge, and secondary outcomes were sustained ROSC and favorable neurologic survival.
Volume's okay?
Both of which I think are good kind of things to look at. It was a large study. It was a retrospective chart review, but there were 10,853 cases from 2008 to 2013. And they were looking at cardiac arrest patients that out of hospital setting, and then divided it into people who had successful intubation, LMAs, and DBMs. So the way that it works in Type A is that BLS can defibrillate, and they also carry LMAs, and in their protocol is basically, if BLS gets there in cardiac arrest, they should defibrillate the person and try and put it in an LMA. If ALS gets there, they will do ALS interventions and try and get a advanced airway NGT2 in. And if after one attempt either are unsuccessful, then they would do BBM on the patient. So they had so after all the patients that they looked at, and they basically had about 2,000 people. They had 2,000 people that the endotracheal intubation was attempted. 1,541 of them were successful, 459 were unsuccessful. They had 2,677 that were LMA, and then 6,176 that were BBM. I think one of the key points of this study was that the CPR quality, which seemed to be very, very good. I mean, they seem like they get at least twice a year. They have their CPR effectiveness checked. They watched their CPR effectiveness on videos, and they really had very minimal times. I think they said only 2 to 5% of all cases had poor performance CPR, which is pretty impressive, at least compared to what we see pre-hospitally and even in the emergency room. How many times are we taking breaks for longer than 5 or 10 seconds? I think it happens
Because
a lot.
we know circulation 2 years ago, the best study ever, for every 5 seconds you interrupt compression, survival goes down by 17%.
So they showed that the intubation group consistently had the best survival outcomes, and that included ROSC and survival to discharge and favorable neurologic outcome, which I think makes sense in the setting of having very good CPR. I think, what was interesting here is that some of the paramedics did do 2 attempts, but their idea was really only 1 attempt and then go to the next measure. And I think that if we are continuously doing CPR and you have someone who is skilled at intubation, and you can do it quickly while still doing CPR, then it makes sense to me that you're going to have better outcomes in those patients than if you're having, then if you're mucking around in the airway, you're not able to get it, and CPR gets stopped. So I mean, in all these, it was statistically significant that these patients did better on all three categories, and did better with the intubation versus the LMA and the BVM. So I think it was a cool study. I think it was interesting to see and read about, and I think it goes to show that definitely pre-hospital intubation is important, and I think also in conjunction with that this continuing CPR and really minimizing the interruptions, and that is really where I think probably the success comes personally.
So this was a big month for pre-hospital and intubation, right? We have the Type A study, we have the Protect 3 trial, which we reviewed, which is another big trial which showed a benefit of paramedics intubating versus not intubating, and we have the French study, which I still haven't found on PubMed yet, but has gotten a couple of editorials. And it showed, so in France, I guess they were pushing to stop the paramedics from intubating the way much of the country does. And they showed, they released their slides, but I haven't seen the paper on PubMed yet. They showed a clear benefit to intubation over alternate airways. So between the French study, the Type A study, and the Protect 3 study, a big month to support pre-hospital intubation. As far as the continuous compressions, confusing literature now. I mean, we have literature that clearly says PICR CPR by observational studies is best uninterrupted compressions. That was contradicted by the best study we ever had, the Nickel paper, in I think 2015, which said people who get ventilations and interrupting compressions actually have better outcomes, and that flies in the face of PICR CPR and continuous compressions. And the Nickel paper was the best paper ever published statistically. And then in children, I think 3 weeks ago, we reviewed the first ever CCCPR paper in children. And we all know that CCCPR is a great thing to be taught in the malls, compression-only CPR, swimming pools in adults. And finally, they studied it in kids, I believe, under 18. And it surprised us all that CCCPR went inferior to bystanders just doing regular CPR. So if you fall down in the mall, the answer is if you're an adult, you do compressions only, and if you're a kid, you interrupt your compressions, and CCCPR doesn't work in kids. I think there's 6 papers in adults that say CCCPR is the right thing to do. And I was just talking about this at Coney Island Hospital, and maybe that's because kids have problems with respiratory arrest, and adults have problems with cardiac arrest. Sure, that kind of makes sense. Maybe that's true. That seems theoretically why they might find the results they did. It's not proven, but it's just kind of interesting that interrupted compressions was better in kids. So if you fall down in the mall and you're under 18, you probably need to ventilate, and if you're over 18, you probably don't need to ventilate. That's what I'm left with as of today in the compression-only literature. Any other thoughts? So I liked it, though. A lot of people are talking about the Type A study right now, and it just came out. And this was in press, right? So here in Journal of Pulmonology, you get the articles already out. You get the articles that haven't even been published yet. Okay, let's do the next one.
Yep, talking about compressions, basically. So the one compressions, compression to ventilation ratio yielding better cardiac arrest outcomes. So this was kind of like a meta-analysis. They review bunch of articles, basically able to point to a total of 28 total studies comparing different ratio, compression to ventilation ratios, and compression by itself. And basically the outcomes they got was like that they favored the 30-2 compression to ventilation rate, which I thought it was pretty interesting considering we were like going more to the only compressions and not stopping to just do ventilations as long as you have good quality CPR. So I thought that was very interesting, but they do point out in the article that, as we all know in pediatrics, which is what I do, most of the cases of cardiac arrest are actually related more to respiratory issues. So they also, of course, favor the fact that you should do ventilations. The other thing that I thought it was interesting is that there was no difference between doing either 30 to 2, 15 to 2, or asynchronous ventilations with that. So as long as you continue to have good compressions, you should have better survival outcomes, but you should still consider doing ventilations in between. So I thought that was interesting on this review.
They talked about the nickel papers, I remember here too.
Yeah.
So what did you guys think about this? So this was, what did you guys think about this? I thought it was a nice summary. And of course, asynchronous ventilation just means you're ventilating with no stopping CPR. So this kind of summarize. I think it's a nice summary in Atlas. I guess it was last week. Okay, any other thoughts about this? No? No? Okay, you want to, how about one more?
Talk about.
Can I interrupt? Because I really want to do the antibiotics. Because we're already talking about CTAs pre-hospitally.
Right.
So this is
So if I get one more question about pre-hospital antibiotics, I get that question all the time. Should we start pre-hospital antibiotics?
Right.
So of course, when a study comes along that starts, or something comes along that talks about pre-hospital antibiotics, we have to at least talk about it.
Right. So this is basically like an opinion article, perspective article out of Emergency Medicine Australasia that proposes the question regarding the timing of antibiotics and the management of sepsis. Can a randomized control trial of pre-hospital administration of antibiotics maybe give us some answers? Kind of the background of
Because
this.
we have to take things into perspective. If somebody's out there saying, "Well, I have 15 minutes to the hospital," well, what if what if there's somebody's watching that's 2 hours to get to the hospital, right? So we don't just think of your own system, think of the whole world.
Right. We're thinking of a whole world kind of thing. And really, the background of this is they kind of delve into the evidence that there's a lot of large studies. The main one that they mention is the multi-center analysis by Freer that had 17,000 patients. And they basically showed for every hour delay of administering antibiotics for every hour delay of administration of antibiotics, you increased mortality. So a big deal, right? And I think that's why sepsis has become a very big national point of trying to improve quality. It's become a major agenda on hospitals. You hear about it nonstop in ERs and staff meetings because it's a big deal. And now it's soon becoming tied to reimbursements to really push the envelope on advancing care.
Right, and to catch everybody up, we reviewed a fantastic paper Josh did last week about evidence-based sepsis management in the first 1 hour, I believe, of resuscitation. So if you want to understand the truth about sepsis, it was a critical care medicine article. Read that article, because so much of what people say about it is just so totally wrong. It's unbelievable. And, that article talked about the lack of utility of lactic acid, despite everybody in the world wanting to get quick lactic acid. Low-level evidence. The article talked about 30 milliliters per kilogram being a made-up number and clear risk of harm when your vials are stable to give that much fluid. So, read that article from last week. It might take a couple of readings to get through it, but it certainly helps catch you up to speed on sepsis.
Absolutely. And so the main question that this opinion piece, this perspective piece offers is that, really we are trying to figure out, is it conclusively, does time matter that much? Yes, we know we should give it early. We shouldn't be waiting days. Probably should be waiting 12 hours to 6 hours. But what about like the first hour or the first 3 hours? Does time make a big difference in that? And the way to answer that would be a randomized controlled trial of having patients present to the ER that are identified as sepsis, giving some antibiotics right off the bat, and then giving others, let's get blood cultures, let's try to identify the bug, and let's try to give them targeted antibiotic therapy. Of course, that's going to be a probably impossible study because most people are not going to feel comfortable, and probably most systems won't approve a protocol that's going to delay antibiotics, because our best guess now is it probably matters about how early you give it. So that I think is a great insight onto where pre-hospital can step in and maybe answer this question. Instead of delaying antibiotics at the hospital, what if we just give them even earlier on the ambulance?
Because what you're saying, if I understand, is if it's hard to do a randomized controlled trial in this in the emergency department because nobody wants to be randomized to the control group where they say, I'll wait 4 hours to get my antibiotics.
Exactly.
But you can do a study which compares pre-hospital and the emergency department as long as you make the patients similar in both control and treatment group and see who might have better outcome.
Right, and I think that is the question of this article, and to that I say absolutely this should happen, especially with all of the emphasis on sepsis. To try to answer this question would be an important, worldwide public health answer that we need.
I mean, you have to pick 2 antibiotics. You can pick more than that.
And so that becomes the complication of then we have to deal with allergies and which patient allergic or
which we could theoretically do, but of the 2 antibiotics we give to most people, one is Vanco. You really can't give Vanco pre-hospital because you get a red man syndrome if you give it too quickly, and unless your transport time is at least greater than 1 hour, I wouldn't be giving vancomycin because you'll never finish it pre-hospital because you have to give that slow.
And then you get pumps on ambulances, or at least good training to slow down your...
Right, so you can do that. You don't know renal function, right, which we oftentimes don't know when we give people antibiotics empirically anyway. Although sometimes we have the advantage of looking at old records and knowing what they are. You'd have to get training and, if somebody's dialysis patient, adjusting the dose. Some of these antibiotics might not be very good in the pre-hospital environment, which is not very well temperature controlled. Just particle motion in ambulances degrade antibiotics faster. It probably does.
The expiration of all the antibiotics that maybe some units don't have that many, but other units in the
nursing home
area.
It's doable.
It's doable. I think from a public health perspective, yes, I think this should absolutely be done. From a practical, trying to do this at a single site would be extraordinarily difficult. It needs large multi-center funding to make it possible, just because of all the logistical challenges. But I think it's a valid question. Practically, if your transport times are shorter, it's kind of like the same. The services are trying to experiment, and then in the article they mentioned some places will give ceftriaxone early if there's clear signs of meningitis.
Right.
Okay, or some services are using a lactate ISTAT to try to identify and move these
terrible signs.
Right.
And then they're making it 2. We used to make it 4. I mean, a lactate of 2. A lot of people have lactate of 2. So when people do, this is the problem with abnormal sensitivities. People still are publishing papers that say most people with sepsis have a lactic acid greater than 2. Sure, that's stupid because most people with a lot of things have lactic acid greater than 2. Right? I mean, if you're in heart failure, your lactic acid is 2. If you're a stomach virus, your lactic acid may be greater than 2 in a lot of people. It's not a very sensitive, or it's not why it's not a very specific marker. Right? I don't know. So I guess do we all agree that if your transport time is 2 hours to the hospital, you probably should get IV antibiotics pre-hospital, right? And if your transport time is 10 minutes, you probably can wait till you get to the hospital.
Yeah, probably.
Yeah. But then you have to, if you're going to create a pre-hospital protocol, what's the cutoff?
Well, the other thing is it will be recognition of it, which is one of our main problems, and that's why you end up having this alarm systems telling you oh, this and this is abnormal, maybe you should consider a sepsis alert. It's that would be another thing. Are you going to be giving antibiotics to people who really don't need it?
Right, but if you're if you have 104 temperature and you're altered and you're 2 hours from the hospital, the problem is that's a lot of pre-hospital patients.
Exactly. And how about the ones that you're in the middle? You have maybe 101 and
so maybe
borderline blood pressure, and you're
So maybe for those people, you start off by saying don't give antibiotics, and you only pick a small select group of patients. But we see people who have 104 temperature who are altered every day. It's not that weird, right? And what would be wrong if we started out something benign, like just saying if you're altered and have neck stiffness and have a fever, you get 2 grams of Herceptin. What if we just start out with that? And if your transport time is 2 hours to the hospital, or 1 hour, That's probably not a bad thing to do. It's a pretty benign drug. If they push it too quickly, it's totally okay because you can actually push Rocephin.
What about
right?
the cost to have this on
Right, that would be the
evidence
question.
and maintain it?
Rocephin's a very cheap drug.
How often do we see these patients, though? I mean, even in the ER where they're pooled, right?
I think
these are-
that pre-hospital antibiotics would be good for nursing home patients who they often come in septic.
Right.
They have a alert system for them.
But maybe you just start off with a select few and then build and build and build as we get more comfortable with it.
Yeah.
I mean, I would target a geriatric population.
Right. And
That would be
might
that would be
the
my
way to start.
like that would be my key like kind of target audience, because these patients are, you know, just in general going to be more amenable to having, you know, a poor outcome. You know, someone who's younger, you know, maybe a little more resilient.
So somebody has to do a study. Then the other question is, do we need a study to just start doing it? You know, if you can do whatever you wanted. If you can do whatever you wanted and it was 2-hour transport to the hospital, would you just tomorrow say, yeah, everybody gets first 2 grams of Rocephin?
Yeah, why not? I mean,
I
people come to
would
the
lean
ER.
toward that, yeah.
People come to the ER. They're tachycardic and fever, and they get antibiotics. We don't know what's going on with them.
Right,
People,
because
a lot of
we
times
know.
they get antibiotics.
Right.
So during the
That's not
winter,
weird. We know.
so my argument is during the winter season when you get a lot of people with the flu, the question is, are we getting a lot of people who are going to end up getting a lot of
Right.
antibiotics for it?
Well, creating a lot of antibiotic resistance because we now
And that's our fault. But the biggest joke is what's the most common drug you give for heart failure, and the answer is Levaquin, right? Because you give a lot of Levaquin, it turns out to be heart failure, right? Because you're in such a rush to give it for pneumonia. We also know that most sources are either lung or urine, right? That's the majority, and then maybe skin and abdominal, blah, and that, you know, brain, blah, blah. But that's why we throw antibiotics in your original patient, because we figured I'm going to give you something that's going to cover both, and I may not be able to figure out both in the next 10 minutes, so why not just, you know, shoot from the hip? But that's not bad, right?
No, I think for our sickest patients, it could definitely help. And even if you have a 10-minute transport, let's say the person's still going to be getting antibiotics, I would say 30 minutes to an hour and a half quicker pre-hospitally than
Yeah, in the
waiting
paper
for
they
the
talk
hospital.
about the on-scene times are average 24 minutes,
Right.
transport times are about 20 minutes, handoff is another 20 minutes, so these people are potentially getting antibiotics 90 minutes sooner
Right.
than
And that's the
even
same
when they're
thing
getting them
with-
right on the
But of course, the difference is if you have chest pain. I mean, the difference is that when you're septic, your sepsis generally doesn't start the moment you call 911, right? So maybe it started the day before. So to do a study, the problem is when you're comparing times, it's going to be very difficult to compare the treatment group versus the control group. Because to know when their sepsis started is very challenging, right? Did it start when they got the fever, when they got their tachycardia, when did the tachycardia really start? When was your first fever? Many people don't check their temperature.
Right.
So how do you compare the treatment group versus control group? You can compare outcomes, but you never know that they have similar baseline characteristics. Because chest pain, you can just say, what time did you first notice the chest pain? With sepsis, you can't say, what time did you first notice the sepsis? So
Especially from a nursing
how would you do a study that really answered the question well? I would almost be afraid of doing that study.
I mean, you get your nursing home patients who say basically that the patient just became altered an hour ago, and clearly you know that that's probably not the case. So the information you're going to get is even
I
skewed.
mean, how often do people say, "Oh, I've only been sick an hour," and then you check their baseline renal function, and it's like doubled, and you go, "Well, renal function doesn't double; it takes like at least 12 hours to really double." So you've been sick for like 2 or 3 days. You know, that's the problem. And you're right. A lot of these people are going to turn out to be, if it's a bad flu season, a lot of these people turn out to be flu.
Right.
And we're going to give a lot of antibiotics. We're going to trigger a lot of sepsis alerts, right? And give a lot of silly 30 per kilos for people who are septic, who are a little tachycardic, or I'm sorry, who have the flu, who are a little
Right.
tachycardic. And we'll do crazy things like check lactic acids, even though it's not very evidence-based. And we'll wind up giving a lot of antibiotics, a lot of fluids for people who probably just have the flu. And truth is, probably could just stay in bed because we have nothing good for the flu because we all think Tamiflu is a drug which has terrible science. Just science, right?
Right.
Despite that, we've all
Maybe your
tried Tamiflu.
Press will go up.
Well, it's hard to say. I know you're here for 104 and you feel terrible, and there's nothing I really have to offer you.
Right.
I can give you some IV fluid so I, as a doctor, can feel better.
Right.
I can give you some Tylenol, which is the only thing that really may make you feel better, or some Advil.
Right.
And what else do I have to offer you?
Nothing.
So I give you fluids, and then I'll give you the wrong fluids because most people give normal saline when they probably need D5 normal to help get rid of ketosis, right?
Right.
and then and some people will feel better, and it's like somewhat super tutorial because if they can drink fluids, why not just let them drink?
Right.
So they feel a little bit better, and they go home, and they're still going to have 7 to 14 more days of the fever, right? And I just helped you for a couple of minutes.
So Sim Shane's asking, how about pre-hospital Tylenol?
Yeah, so I'm presenting this for New Jersey at the December something MAC meeting.
Is he saying IV or PO?
He's saying IV, I'm sure.
I think if you're going to do, I think you need to get a temperature if you're going to be giving people Tylenol.
Right. Well, of course, if anybody read this month's GEMS, we did a paper on pre-hospital fevers. So read this month's GEMS. In January, we're doing pre-hospital TXA and GEMS. So that's a concern that a lot of people have shared with me, that if a paramedic gives IV Tylenol and somebody has a fever, they may block that fever, and now they don't know the person has a fever. Yeah, what'd you say?
Does it really make?
Does it really make a
I
difference?
think it does.
Right. I mean, that's a good question. I mean, if
We do that on pediatrics all the time, right?
you give them Tylenol and triage.
Or the parents will give them Tylenol.
Right.
You're not sure if they have it or not. You observe it, you see how they're doing. You see their vital signs. Is it really important?
I'm just trying to think. So, if a nursing home patient and they got IV Tylenol because it's aches and pains, they had a fever. Now they come in, they have no fever, and they're a nursing home patient.
But they tell you they had a fever, or the nursing home tells you they had a fever.
If they tell you that,
I treat it like
sure.
they have a fever.
I guess that's a good point, because the nursing homes will oftentimes give Tylenol or Motrin, and they come in and they have no fever anymore. But somebody documents on the transfer sheet they had a fever. I think, we're going to review some of the Tylenol papers. Massachusetts just started giving IV Tylenol. They got criticized for it in the comments when they did this. But I don't know that it's the wrong thing to do. It's definitely a little expensive. It's not massively expensive. It's
It was
definitely
much less than it used to be.
Right. The other thing is, IV Tylenol, as we know, is certainly not going to help you with compound fractures, right? There's not great literature that it helps with severe pain. That's true. It mostly got used initially in post-op patients. There was just another article, which I didn't include, on post-op surgery patients being very beneficial. And it was in some surgical journal, I forget which one. That was all floor patients, not emergency department patients. But it probably won't help severe pain, but will it lessen the utilization of opioids? I think that's a good question. Maybe it is the right thing to do. I don't know. I'm not against. I'm certainly not against it. Might there be some people who get it for liver failure? Yeah, I guess. I mean, same thing. There's probably some nursing home people who get PO Tylenol who are in liver failure, and we don't know. So
And should they carry Toradol as well?
Right. So Toradol is interesting. There was a big paper, despite the fact we're giving Toradol for a lot of people with undiagnosed abdominal pain. There was a paper that said in non-cardiac surgery, you give IV Tylenol for patients who are going to the OR, they do have worse outcomes. Despite that, I see a lot of people giving IV Toradol for people who have undiagnosed abdominal pain.
All the time.
All the time. Doing it all the time.
I do.
And it certainly could, make your renal function worse. It is a non-steroidal. I don't know. I'm not against any of this, but I certainly think that if you have severe pain, IV Tylenol by itself is probably not going to do the trick. But it could do the trick in some people.
I think it's nice to have it added to the armamentarium. But also, does IV Tylenol, IV acetaminophen come in single dose? I've only seen multi-dose vials.
So that I don't know. I'm sure somebody can answer that question first. Is there a multi-dose done?
Multi-dose.
Have you seen you've seen single dose?
Yeah, it was like with the gram.
So, are you giving any kids IV Tylenol?
We do. Sometimes we might be working on a study actually for IV Tylenol for 6 months.
Yeah.
Actually. So, we'll see.
Yeah.
We don't use it that often unless they're really
Many hospitals
PO,
restrict it,
but
right? That is kind of funny. We're talking about all over giving it IV, but many hospitals won't let you just automatically give it. But that's more because of the cost.
Yeah. But if we want it, we have it.
Right.
We just don't use it.
I mean, if
that
we're going to do
often.
IV Tylenol, the next question is what's wrong with us giving PO Tylenol pre-hospitally? Because if your gut's working, why not just give it by mouth?
And I think the argument
Because
for a lot of
even
people,
rectal,
right?
like,
That's
we
because a
still
lot of
do
people say
rectal.
they're altered, they can't take PO. Well,
Right.
then time to flip them over. Let's get it
Unless
going.
they're like hemo patients, which you're not supposed to do anything rectal, we still do that all the time.
Can you give IM Tylenol? Can Tylenol be given IM anybody? Because
Never
Crush
seen
it out very well.
It'd be a large volume. That's the only problem.
there's a large volume.
Right.
Yeah.
So I mean, to give even a gram, it's a pretty large
I
volume.
mean, we
you
give
have to
we give adults rectal Tylenol all the time, right?
Right.
Yeah, maybe it's totally okay. I don't know. Maybe the more I thought about this, the more I'm warming up to the idea. Although I still think that if you have severe pain, just be prepared that Tylenol may not work. Right? But I'm warming up to the idea. We'll present. We'll do before the December meeting. We'll do like a couple of the Tylenol articles. I'm not aware of any pre-hospital Tylenol article. Maybe somebody who's listening will prove me wrong, but I'm not aware of it. Although, we could start giving on a physician vehicles tomorrow, and then we could give it to a bunch of patients and look at their outcomes and do a case series of pre-hospital Tylenol. Of course, the argument will be, well, if Massachusetts is already doing it all the time, what's our case series of publications really going to prove in literature? Right. We'd have to do something where we randomize people to get it versus not get it with similar baseline characteristics, and then we run into the same problem that when did their fever really start? When did their sepsis really start? When did their infection really start? Is there a difference?
Well, and maybe the utility is less for fever, but maybe especially people who are maybe have a history of opioid abuse, and they'll flat out turn down any opioid painkiller. Maybe it's a good option for them in trauma or pain, especially if we're worried about Toradol. Again, just like have another option for some of these people.
Increase your return.
Increase.
But we can talk more about this during our research meeting. And is there anything else? Do you have articles or?
It's
like
21. So yeah. So why don't we just stop? So this week was really cool for a couple of articles. This week's New England Journal of Medicine had a great freaking article, Diuretics and Heart Failure. There was actually a lot of pathophysiology, if you're interested in the glomerulus, a lot of cool pictures and stuff. And I read it like 3 times. I kept shouting out, this article is just great, this article is just great. There's a whole section on Lasix in acute decompensated heart failure. And to summarize the bottom line, we've written 3 clinical pearls about this. We have no freaking idea what we're doing with Lasix and heart failure. No idea, no idea, no idea. And there's only one randomized controlled trial in literature that's good, and that's the dose trial. And the dose trial says the opposite of what Amamatu says, which is more Lasix is better, right? Higher dose is better. And although your creatinine does bump up in the first 72 hours, it goes back down to normal, and there's no difference in outcomes. And you probably don't activate the renin-angiotensin aldosterone system more by giving high-dose diuretics for slow dose, which is the opposite of what we used to think by several studies. More recent studies says you probably don't do that. So generally better outcomes, which is what we showed with our pre-hospital Lasix trial too. Better outcomes in people who have higher doses of Lasix for acute decompensated heart failure. Although I am still, part of me is still in the Amamatu camp, which says not everybody in heart failure needs diuresis. Some have, because there's plaque sequestration and because of ischemia, probably don't need diuretics. Although that's certainly